controversies nowadays going around the possibility of aerosol transmission, and I would like to raise, the evidences to and against about the possibility of aerosol transmission. Because if we accept that, SARS-CoV-2 is transmitting through aerosols as one of the major means, then we have to really make lots of changes in our preventive efforts. The other point which I'm going to discuss is about the serologic response. An interesting paper has been published in Nature and with a case, and I will present you the evidences with an actual case. Features of antibody response in convalescent individuals, current data pertaining to the use of steroids, and the role of non-invasive ventilation in severe COVID-19 cases. Okay. So just 2 weeks earlier, this is something really good, when I read about good things about Ethiopia in the news, really all of us feel really happy, because the oldest man who has survived COVID is from Ethiopia, and this is a man whose age is 114, and this is broadcasted by BBC, and the doctor who treated him, Dr. Huluf, is our staff, and he recovered. He had severe COVID. So this is something really good about our country, because, in the history of COVID, the oldest survivor is from Ethiopia. So if we see the profile of what is going to happen, with this pandemic, there are 3 possibilities. The first possibility is we'll have peaks and valleys, meaning spikes, and following preventive measures, there will be a declining in the number of cases. And when you see the second case scenario, there will be peaks and low levels. And the third scenario may be best exemplified in Singapore, China, and Hong Kong and the like, where the number of cases is substantially low and the peaks are controlled. So when you take, this all depends by our first control measuring our first control the disease. And now we have a vaccine. I'm going to tell you about the advances in relation to the vaccine. And I think this disease is going to stay for us for a minimum of 2 years, during which time, with this, with the level being a pandemic. So we have to really come out of the emergency state and take it as, we have to still continue with our preventive measures and other measures too, and we have to really come back to our senses and resume our activities with maximal care, because I think Ethiopia's condition would fit either the one or the peak and valleys or the falling peak. I don't think the slow burn would be the case in Ethiopia. So we'd be having peaks now, in the world today is nearly 15 million people are infected, reported, out of whom more than 500,000 died. In Ethiopia, more than 10,000, and of whom more than nearly 170 people had died of the disease. So we haven't yet come to the peak of the disease. So the issue of airborne transmission has been given due emphasis, including by WHO. And in the transmission of the disease, what you need to understand is, from the infected person, secretions, droplets or aerosols come out. The difference, the difference between droplets and aerosols is size. Droplets have a size bigger than 5 microns. And if you want to understand how big microns are, if you take a hair, a single hair, and you slice it, the diameter is 80 micron, 80. So these are very microscopic, okay? So the difference between droplets and aerosols is size. So size goes with density or weight. So the heavier the size or the density is likely to fall. So it can't go beyond 2 meters in case of droplets, but aerosols would remain suspended in the air and could go as long as 7 to 8 meters. So if we accept that SARS-CoV-2 transmits through aerosols, what we advise, the distance between individuals being 2 meters is not sufficient. So people should be apart by a minimum of 7 to 8 meters. And the surgical masks also cannot prevent aerosols because the size, their capacity to prevent aerosols is only 30%. So if we assume that it's spreading through aerosols, then we have to change our preventive strategies to routine N95 masks and including head cover as well as face covers too. Okay, so the discussion has been given due emphasis, and a group of experts, more than 200, have written a consensus letter to the WHO, and still the evidence are being examined. And what we have understood is the major mode of transmission is through droplets and contacts with contaminated fomites, because droplets cannot remain suspended in the air because of their weight. They fall to the surrounding objects, fomites, and then when we deal with these fomites with our hands will be contaminated, and then if the contaminated our hands have access to our upper respiratory tract, then this is how it's transmitted. So the main mode of transmission from the evidences collected so far falls to either droplets or contact. However, in closed circumstances where there is less ventilation, low humidity and high temperature, there is a possibility for small size particles, aerosols, less than 5 microns to remain suspended. And when there is less airflow, then people can get infected. So there is a possibility of the disease being transmitted through aerosols. However, still the controversy is going on. And some of the evidences that are given against aerosol transmission is, if you take the basic reproductive rate of COVID-19 is still 2.5. It falls between 2 and 3, meaning an infected individual will infect between 2 to 3 other individuals. And is a good example for a disease that's transmitted through aerosols is measles. So if you take the measles, row of measles is 18. So a single case can infect 18 or more. So still, if aerosol was an important means for the transmission, so we would have expected a lot more from the primary case. And another case against aerosol being a primary modality or mode of transmission is a secondary attack rate, which is 5%, meaning the number of cases that projects from the secondary case, from the original, from the primary case. So in conclusion, what I would say is, still droplets and contaminated fomites play the major role. However, we can't neglect in areas where patients are being cared for and where aerosol generating procedures are being made. And in fact, aerosols, now we have come to realize that they could be released or remain suspended in the air while speaking, singing, and coughing. So in closed rooms where there is less ventilation, there is a possibility of getting infected with aerosols. So this is a picture. This is a moving picture. What you can see here is the difference between, aerosols and droplets. You see the smaller particles, the bigger particles fall to the ground. These are the droplets. So they would contaminate the surfaces surrounding us. The smaller particles will remain suspended in the air and can land, can easily be inhaled. And you see the fog-like structure is the aerosols. So they can, depending on the movement of the air, it can go up to 7 to 8 meters. So, this, if WHO accepts aerosols as a third, maybe significant mode for the transmission, then it means that we have to change our preventive strategies, like the routine face masks or closed masks should be substituted in some circumstances with N95 mask. And the problem we are facing with N95 mask. So WHO and other experts are taking this seriously and trying to generate, facts which would support either one of the two. Okay? So this is about aerosols. And what we have come to realize is masks are really helpful. In fact, in a patient, this here you see a patient who is using high flow nasal cannula. And this is a patient with COVID. When mask is applied, so you see this is without mask and this is with mask. So you would see less, or in fact, significantly less droplets and aerosols being released to the surrounding. So even patients, while being cared for, known patients, diagnosed patients with who require non-invasive ventilation, or in fact, even invasive mechanical ventilation, if masks are applied, then it would, substantially reduce their probability of contaminating the environments, the surrounding environment. So this is another example whereby, this is quoted a lot, more often these days in Washington, a choir, their number was 60, and none of them were symptomatic. They kept the 2 meters distance, and they were careful about hand hygiene and the like, and there was no one who had symptom at that time. The choir, after they had a practice, 3 weeks later, out of 60, 45 got infected and 2 subsequently died. And in conditions like, where people are exercising, with choirs, for singing, like in a choir, or in where they are performing physical exercise in closed rooms and the like, in restaurants, it's possible to get infected through aerosols. Okay. The controversy in the United States is, all these facts suggesting that masks are really helpful. Still, Donald Trump, has refused to admit, the Americans should use masks, even given the fact that the US has the highest number of cases, and most mortalities are also from the United States. Okay, the take-home message is experimental data supports the possibility of SARS-CoV-2 being transmitted through aerosols, even in the absence of aerosol regenerating procedures. And however, we haven't yet come up with any dose response, or we haven't yet figured out the infective dose of SARS-CoV-2. Because what we need to understand is this is a universal rule in infectious disease. The higher in the exposure you have to the high burden of a disease, any disease, infectious disease, the more likely that you are going to get. So what we have come to realize is in closed spaces where aerosols would accumulate and there is less air circulation, it's possible to get infected, even with surgical masks, and face shields also wouldn't offer protection against aerosols. So what we suggest now is when we are dealing with patients, we need to keep the doors and windows open so that we have to make sure that the air is circulating, provided having still masks and face shields too. Okay. So the other issue which I would like to discuss is about serologic response associated with asymptomatic COVID-19 disease. A true case, a surgeon in the United States tested positive for SARS-CoV-2, and he had very mild symptoms. So he felt he was very lucky. And 4 weeks later, he decided to get antibody testing, but unfortunately, his antibody testing was negative for SARS-CoV-2 IgM and IgG test. So what do we, and this is a true case, so what do we understand from this? The paper published in a very interesting paper published in a high impact journal, Nature, to assess the clinical and immunological differences between patients who had symptomatic disease versus asymptomatic disease. And as you would see, asymptomatic ones would shed the virus longer than symptomatic individuals. So what we understand is the host immune response is less with asymptomatic. So the more response you have, the more vigorous one's immunity against the virus is, and the individual is likely to be symptomatic. So the ones who discharge the virus longer are asymptomatic. In our case, I repeatedly get a consult about people still remaining positive for RT-PCR with having no symptoms might fall to this category. The symptomatic shed the virus longer. And another thing, very, very interesting thing that has been noticed is if you see the antibody response, the symptomatic are ones who are likely to become antibody positive. This is an IgG response. So it's only 60% of asymptomatic, whereas 87% of symptomatic individuals. So what we understand from this is people who had asymptomatic disease have less antibodies. So what that means is they have a chance to get reinfected. Compared their probability of getting infected, reinfected is more compared to an individual who had symptomatic disease. And another thing is, which we have come to realize, is a protective immunity might not be long-lived. This is something which is also striking. And so this is when we think about the antibody response. And another paper also assessed the convalescent sera in patients who are recovered from COVID. And what has been shown is high antibody titer was seen after the 39th day in only few patients. If you take, majority had low titer, and if you take 1 in 1,000 is 79, and this is highly effective. So it's very few that who had high titer of neutralizing antibody against S antigen. But interestingly enough, this is the humoral immunity. There are other antibodies detected against, this is for the total S antigen, so for the receptor binding domain, and the cell-mediated immunity is found also to be more stronger in those who are infected than compared to their controls. So what we have learned from this is, so you should not go for antibody alone, and there is also a role to be played by the cell-mediated immunity. So the earlier approach to the disease was we were assessing immunity against the disease with a humoral aspect only, but now lots of evidences are emerging that to show the cell-mediated immunity has also a role to play. Okay, this is also another which strengthens the role of the cell-mediated immunity too. So there are encouraging news about vaccines. The two vaccines that, I mean, there are now nearly 20 vaccines on being tried on human beings, but the most advanced ones, or the most promising ones, are the Moderna vaccine. This is a very interesting vaccine. In fact, the first one in its kind, because they just took the whole genome, identified the segment that codes for the S antigen, and they took that gene and incorporated it or encoded into the messenger RNA, and they give that as a vaccine. So no courier, no no other viruses. The other ones use other viruses like adenoviruses and the like. So what has been shown from this is the phase 1 study is published in New England. New England Journal of Medicine never published phase 1 trials, but this is something really remarkable. So they assessed 25, 100 and 250 micrograms dose. They give also booster, and what they have seen is the immunogenicity really. So all doses are immunogenic, and no serious adverse events was seen. And now they are going for 100 microgram versus 50 microgram in a phase 2 trial, and at the same time a phase 3 trial has already started, and the vaccine production has already started. So maybe in September or November, September, October, people are going to be vaccinated, and this vaccine is controlled by the USA. And yesterday, vaccine from Oxford and AstraZeneca also showed a very promising result. They published a phase 1, phase 2, safety as well as immunogenicity trial, and it's published in Lancet and showed a similar effect. In fact, here, maybe more important than the Moderna, the cellular immune response is shown to be much better. I can't say much, but shown to be better. So these are two promising vaccines which are going to come in the coming few months. They have already started phase 3 trial in Africa. South Africa is part of the vaccine trial, and I think the rich countries have controlled. Already United Kingdom bought 100 million vaccines from the AstraZeneca. So access, the equity for access and the like would be really an issue when these vaccines are going to be used in public. So it's a very good news. Another good news which I have for you is the trials with steroids. Okay, so far, none of the clinical trials showed mortality benefit. However, the recovery trial from the UK showed really low dose dexamethasone really works. So the recovery trial has included more than 11,000 individuals, and there are more than 6 groups: standard of care, hydroxychloroquine. Hydroxychloroquine data is out, it doesn't work. So from now onwards, we shouldn't discuss about hydroxychloroquine and chloroquine, because there is lots of data which shows that it doesn't work. In fact, it's more deleterious. So the lopinavir, ritonavir, no satisfactory data, result. Azithromycin again, the data is not yet out, but the preliminary report shows it doesn't work. Tocilizumab, this is anti-IL-6. I think there is no favorable, the data is not yet out. And in relation to the convalescent plasma, they haven't released the data. However, the dexamethasone data is released because it really showed an important finding. It reduced days in patients who required mechanical ventilation by 1/3, and patients who required oxygen by 1/5. This is what you can see here. However, when patients not requiring mechanical ventilation, okay, are taken into consideration, all patients, it didn't show a day's benefit. So when the data is analyzed in subgroups, so people who did not require oxygen did not benefit, in fact, had more days. The dexamethasone group had more days compared to the standard of care. However, those who benefited most are people who required oxygen through non-invasive means, and patients who required hospitalization and with invasive mechanical ventilation. What you need to see is the mortality rate in UK is very high. Such high mortality rates was not seen in China and in most areas in the US too. So maybe here, more inflammation, more advanced disease, more cytokines. Maybe that's why such a profound effect was seen. So if this study is repeated in other areas where the mortality rate is lower than 40%, I don't think we would see such a high effect. However, I have no doubt that it really works. Okay, provided that patients have severe illness requiring oxygen or mechanical ventilation. Here you would see difference in all participants, usual care and dexamethasone. So more mortality was significantly higher in patients who are given the standard of care. Whereas if you see, if no oxygen is required, so the usual care or standard of care did better. So what was not really, the information here is missing. So what did the patients die of? Those people who did not require oxygen, what were their cause of death is not yet released. So maybe when the full paper, now it's a preprint, so maybe subsequent papers are going to come, and that is going to, I hope that would be discussed. Here you would see how beneficial is for patients who require oxygen. And in fact, the benefit is very prominent when invasive ventilation is required. So the study was stopped prematurely because the DSMB has confirmed that enough patients were recruited, both in the study arm as well as in the control arm. And when analyzed, really, the study showed significant benefit in that dexamethasone reduced days by 1/3 in those who are ventilated, and by 1/5 in those patients who required oxygen. And the number needed to treat to avoid 1 day in ventilated patients is 8. So how we calculate number needed to treat is 1 over absolute risk reduction. And so the number is 28 for those who are on oxygen. So this means, very significant effect, okay? So nowadays, in fact, all countries in the world have adopted this and are using steroids, dexamethasone in particular, for patients who require mechanical ventilation. However, you see, if you go back, the road to this finding was not really smooth. It was bumpy. This was published in early February, and we showed And this is published in Lancet, and it's discouraged everyone, stating that they reviewed the facts, in relation to MERS-CoV and SARS-CoV-1, and they showed that, from the review and including influenza and respiratory syncytial virus, steroids are not beneficial. However, the group from China had really argued against, because they showed that steroids, if used in selected patients, with ARDS, they in fact are the ones who published the first paper that showed steroids are useful in patients who have severe disease like ARDS, who required mechanical ventilation. However, because that was only one study, people didn't